Good morning, everyone. How are you? Thank you for such a kind and generous introduction. I appreciate that very much. And I am absolutely delighted to be here. I want to thank Bill in particular and all of the planners and sponsors for this opportunity. I also have I think I'll use the word confession to make. I've been engaged in this work for a very long time and had many opportunities to do a range of things to support people with disabilities and their families. While I'm very, very familiar with the topic of health disparities at the intersection of race, ethnicity, and disability, I would say that Bill truly challenged me to look at this within the context of faith communities. So that is my confession. I hope you will bear with me. I hope you will bear with me in terms of what I put together for us for this morning. But again, I'm making a declaration up front that this was challenging for me, and actually a very good challenge because it made me grow. Thank you again, Bill. All right, so what we're going to explore today together. Rather than objectives, I thought that we would just have plain speak and look at things that we can explore together, not just today, but also throughout your time here in Raleigh. I didn't want to make an assumption that we all knew about health disparities. They're defined in very different ways. And so I'd like, first of all, for us to have a shared understanding of what are health disparities, what are health care disparities, and to differentiate health inequities and health equity from those terms. Oftentimes, people use these terms interchangeably. So we're going to spend a little bit of time with that today. I'm going to share some about what we know and what we don't know about health disparities among people with disabilities. And I would say we don't know a whole lot. And lastly, we'll look at faith communities and what they can do to partner with people with disabilities and their families to address health disparities. So again, I'd like for us to maybe get on the same page. And perhaps before I start, at your tables, maybe just for a few minutes, you can have some discussion about your understanding of what a health disparity is. Talk among yourselves. Just a few minutes. frameworks for thinking about health disparities. And we're going to first start off just with the term disparity. As we think about a disparity, it's a difference. It means that something isn't equal, and there's a lack of similarity. And so when we hear disparities, oftentimes people attribute a negative connotation to that term. Disparities in and of themselves are not bad, nor good. They're just a descriptive difference. And I tried to come up with some images with the two figures that are there that just shows a disparity in height. So if we think about defining health disparity, it really can be thought of as a chain of events, and again, using the term difference. And that's difference in the environment, access to and utilization of healthcare. And I want to emphasize that, access to and utilization. The quality of healthcare, the health status of individuals and or populations. And then in particular, a health outcome that bears scrutiny. So that is one way that we can begin to think about defining what is a health disparity. I want to differentiate that definition about health disparity with the definition of health care disparity. And again, it may sound subtle, but it's very important to differentiate the two. So if we look at health care disparities, there are differences in the quality and treatment of care and other services that may be provided within our healthcare and medical and behavioral health arenas. And so if we look at that, these differences, when we compare them from one group to another, and these groups can include, differences can include insurance, just how one gets to care, needs and preferences, and most importantly, these differences in care cannot be explained by disease or illness or the health status of the patient. So that these are overt, sometimes subtle differences, but we can't say that we would attribute it to, I would say, personal qualities, disease or health status of an individual. So that's how we're looking at health care disparities. And so if we think about this concept of health disparities, they are the product of health inequity, meaning that it's a particular kind of health difference that is closely linked with social or economic disadvantage. And that's based on just a person's identity and their place in life. And it may include their race or ethnicity, their religion, their gender, their sexual orientation or gender identity. It may include where someone lives or in location or place. It can include socioeconomic status, cognitive, sensory, or physical disability, and it can include mental health. And then other characteristics by which we find people in the United States, its territories, and in tribal nations who are discriminated against because of these qualities. So this is a very distinct aspect when we look at disparities as it relates to inequity. So let's talk about what are inequities in health. So when we think about inequities, these are things that happen within our society that put people really at greater risk with their health because of the backgrounds of the groups to which they are members. And again, it compromises their health and well-being overall. And I'm using health broadly, and we'd like to include mental health of individuals, behavioral health, and well-being. This is from the work of Paula Braithman, who's done some incredible work in the area of health inequities. And her definition, which I'm quite partial to, is looking at health equity as the absence of systematic disparities. And we all are now on the same page about what disparities are, or in the major social determinants of health. And I know you're quite familiar with that term. And this is, again, between social groups that have different levels of underlying social advantage and disadvantage. Again, where people are placed in our society. And we know that health is really essential to all aspects of our daily lives. So this is saying that those things are removed, but they aren't there. They're not barriers. So I'd like to offer a framework, again, that we use. And at the very bottom of this, and I may read some of this because it may be very small for you to see, is if we look at what in our country are our health and behavioral health policies and the amount of resources we allocate to health. So this is both in the public sector and the private sector. Those resources and policies directly affect what care people get, what services they get, what supports they get. And that's looking at the availability of such health services, the accessibility of the health services, also looking at the acceptability of health services, so that it may be there, it may be offered, but it's not accessible to me or acceptable to me because the manner in which it's given. And lastly, the utilization. So all of these things come together when we're looking at the impact of policy and resources on the health and well-being of people, including people with disabilities. And lastly, as we look at these policies and resources that affect this range of things in terms of care, services, and support, then that has a direct impact on the health and well-being of populations. This will be individuals, families, and communities. And so all of these things are interrelated. And I think it's important for us to be able to look at that they are connected. They're not in isolation. So, how many of you have heard of a young boy by the name of DeMonte Driver? Raise your hand. Anyone? All right, so what I'd like to do is tell the story of DeMonte Driver. I have a colleague that Bill knows in New Jersey who's at Rutgers University. He's a physician. He's done a lot of work in the area of health and healthcare disparities. His name is Robert Lyke. And one of the things that Robert always shared is that we know many of the statistics, we know the numbers, and he describes those as people with the tears wiped away, because we don't see the people, we only see the numbers. So I want to share with you the face of disparities through this one young boy. So DeMonte, who lived outside Washington, D.C., quite frankly in an affluent area in suburban Maryland that has the highest percentage of high-income African Americans in the entire country. This young boy lived in a family that was not that quite affluent. And his mother could not find a dentist, not one, who would accept Medicaid. And while she was trying to seek care for her son, he had an abscess that then infected his brain. So he went from a toothache to a bad abscess that affected his brain in this period of time, trying to seek care. He then had to have multiple surgeries and with a significant cost of care. But unfortunately for Demonte and his mother, it was too late. This young boy died in 2007, all because he could not get care that he needed. That all started because of a toothache. This is the face of disparities in our country. I know this isn't probably the most positive note to start off this talk, but I really want us to understand the consequences of health disparities and how they impact people with and without disabilities. So that was in 2007, and let's look at this area of disparity to see where are we now. So after Demonte's death, there was legislation that was introduced in Congress in 2008, but it wasn't passed, to really look at ensuring that Medicaid would cover dental care for children. In 2009, the Children's Health Insurance Program was reauthorized, and they were able to, at least in that legislation, provide for dental care for children enrolled in Medicare. In 2010, the Centers for Medicare and Medicaid Services created an oral health initiative. Then later, in 2014, the Affordable Care Act was passed that had a requirement to ensure that children could get dental services if they were insured through Medicaid. Now, if we fast forward to 2016, there hasn't been significant changes. The Department of Health and Human Services, Office of the Inspector General, in a recent report that was just published, you can find it online, found that 3 out of 4 Medicaid-insured children did not receive all of the required dental services, with 1 of 4 failing to see a dentist at all. So my image earlier, in terms of looking at what are our policies, what do we allocate in the way of resources, what then happens in the way of accessibility and availability of services, and then what happens to individual people. Demonte is a good example of that, and we have not made the progress that we should have since 2007, when this young boy passed away. So if we continue to look at where we are now, in 2015, Medicaid and other forms of public insurance covered more than 11 million people, 25% of whom were African American, and more than 18 million were Latino and Hispanics, with children disproportionately represented in these numbers. In 2017, more than 53 million people lived in areas of the country that the federal government designated as having a lack of dentists. And individuals from racial and ethnic groups other than non-Hispanic white are also disproportionately represented among those that have no dental insurance. We're going to come back to look at what this means, in particular for people with disabilities. So as we think about the factors that contribute to health disparities, they're complex. They include, again, socioeconomic status of individuals, their culture, differential access to health care, insurance, really looking at biases that we see within our healthcare delivery systems, the built environment, and public health policy. There are more. They probably just simply couldn't fit on this graphic. So I don't want us to think that this is all-encompassing, but these are complex things that help contribute to health disparities. So what do we know about health disparities among people with disabilities? And I'm going to ask you to engage in the same opportunity to discuss among yourselves. Given these definitions that we've just shared, what do we really know about health disparities and people with disabilities in our nation? Talk among yourselves for a couple of minutes.
And things that we know as it relates to individuals who are at the intersection of disability, race, and ethnicity. So I'm going to share with you some general things really quickly in terms of what we know about people with disabilities and health disparities. This is from the work of Gloria Braun and her colleagues, who has been a big proponent of looking at public health issues impacting people with disabilities. So I'm just going to go through these really very quickly. These are things you may already know. That as a group, people with disabilities fare far worse than their non-disabled counterparts across a broad range of health indicators and social determinants of health. Adults with disabilities are 4 times more likely to report their health to be fair or poor than people with no disabilities. Adults with disabilities are 2.5 times more likely to report skipping or delaying health care because of cost. Although they have higher rates of chronic diseases than the general population, adults with disabilities are significantly less likely to receive preventive care. Mental distress, such as depression or anxiety, is a common concern for people with disabilities who are also less likely to report receiving adequate social and emotional support. Population research has consistently documented that women with disabilities receive lower rates of clinical preventive services, such as mammograms, and receive differential treatment of detected cancers, including breast cancers. This is work in which I was engaged along with Gloria Cron and a number of others in terms of looking at what we are calling compounded disparities. So people with disabilities have much poorer health outcomes, with many of these poor outcomes believed to be preventable. And I think that that's significant, preventable, and we're not preventing them. Adults with disabilities are also more than twice as likely to report unmet mental health needs, so that many times we're focused only on the disability and not with physical, spiritual, and emotional well-being. Children with special health care needs are more than twice as likely as their non-disabled peers to report unmet health care needs. And circumstances of incarcerated persons with disabilities highlights complaints that prisoners are routinely denied attention to their mental or physical needs. The inmates receive inequitable access to facility programs and activities, and there's a lack of effective communication for inmates with hearing or vision loss. These are all compelling data. So let's come back to oral health in DeMonte's story, and to look at that, how this impacts children and adults with disabilities. Children with intellectual disabilities and developmental disabilities are more than 30% more likely to have their first dental visit delayed. Part of that is that we're not dentists who are trained to work with this population. Very few. In addition, studies have shown that children with intellectual disability and developmental disability were not likely to receive preventive care. We continue to look at oral health. Individuals with intellectual and developmental disabilities have significant dental needs, and these needs are often untreated. Unmet dental needs often result in individuals with intellectual and developmental disabilities having poor oral health, with dental needs that are more severe than individuals without such disabilities. And unmet dental needs affect negatively their daily activities for individuals. And I think when I was reading the study, it talked about the pain that people suffer because their dental needs are not met. When we look at these dental needs, again, they span the gamut, so that individuals have poor oral hygiene and more gingivitis and periodontal disease. They demonstrate more dental caries than the general population and have an increase in distractions. These are vivid examples of what it means to have health disparities. And so our understanding in terms of looking at health disparities at the intersection of race, ethnicity, and disability is very limited. We need absolutely more studies that looks at the experience of people at this intersection. And there's implications that at this intersection, because of their race, ethnicity, and other factors for which they're discriminated against, that the impact of the disparities are indeed multiplied. So what do we know about health disparities at this intersection? Hispanics or Latinos and non-Hispanic Blacks with intellectual disabilities were less likely to have received recent preventive care than non-Hispanic whites with the same disabilities. African American and Black women with intellectual disabilities were significantly and substantially less likely to have received a mammogram compared to white women with the same disabilities. In particular, African American and Black youth with muscular dystrophy had lower overall health care use and less of primary care, therapy, and specialty care, but higher use of emergency rooms. And African Americans or Blacks and Hispanic and Latino parents of children with developmental disabilities have reported poorer quality interactions with healthcare providers compared with white parents. People in underserved racial and ethnic groups, especially African Americans and Blacks, continue to be overrepresented in nursing homes. So again, in institutional care. Nursing homes with high proportions of African American and Black or Hispanic or Latino residents are more likely to be of poor quality. And people with disabilities and older adults in underserved racial and ethnic groups experience substandard long-term services and supports. So again, these are pretty compelling data that looks at the disparities that we have in this nation that impact all people with disabilities and perhaps in greater degree people at the intersection of race, ethnicity, and disability. So, these underlying factors that contribute to health disparities can seem overwhelming. They certainly do seem overwhelming to me. It's like, what can one person possibly do? And so, I want to pose to you, given this reality, is what are some things that we can do within the faith community? I'd like for you to consider the levels of influence within faith communities. Things you can do at an individual level, things you can do within your churches, synagogues, and mosques, what you can do to impact the local or state level, and what you can do at the national level. And I've broken it down into those categories. So I'm going to go through these, and then you'll have time to discuss them at your tables. So first one is looking at talk the talk and walk the walk, because both are needed. What's important is for you to do at an individual level is to acquire cultural knowledge about health disparities that impact individuals with disabilities in your community. So I wasn't privy to your conversations when you were talking about that, but the extent to which you know and understand these disparities helps you be in a position of advocacy. Educate members of your faith communities about these significant problems that are impacting people with disabilities each and every day. Engage in advocacy. Think about you stepping up and stepping into the void and leading an initiative to address the barriers that people experience. This could be at a very small level, that you help with the provision of transportation, or you support efforts around health literacy. And to consider thinking of practicing nothing about us without us by respecting the leadership of people with disabilities and their families in this area. So if we look at this within your mosques, synagogues, and churches and other places of worship, things that you can do is to increase the awareness of health disparities that impact individuals with disabilities, their families, and quite frankly, the communities in which they live. Look at seeking partnerships with healthcare, social service, and educational programs that are concerned with health disparities. So in other words, I think it's very difficult for faith communities to, quote, do this alone. It can only happen through partnerships. So we have some excellent examples of partnerships that we documented through community health centers that were partnerships between faith-based and healthcare organizations to really focus on these specific areas that impact people. Educate policymakers and legislators across the country about health disparities and how they in particular affect people with disabilities and their families. The disabilities community was very powerful when there was efforts to stop the Affordable Care Act. I dare say that their voices and their families' voices really put on hold some of the policy changes that were trying to be implemented in Washington, D.C. So the extent to which people understand and know that there are people that live in counties, in their states, that don't have access to services or have very inadequate access to services is key and critical for all of us. I also encourage you to consider adding disability as a social justice issue for faith communities' action agenda. I've used some words pretty deliberately, including assert political will. Acquire knowledge about health policy and resources that impact people with disabilities. It's really key and critical. As we go back to that graphic, the policies and resources impact pretty much everything. Join coalitions and networks to advocate for policy changes to reduce health disparities in general and those affecting individuals with disabilities in particular. Consider developing approaches for faith communities to offer testimony to state legislators about policy and funding that contribute to or perpetuate health disparities for individuals with disabilities. And lastly, advocate for health equity, because we now have a shared understanding of what that term is. So if we look at the national level, really consider partnering with people with disabilities and their families, and use education and advocacy to influence the platforms of national faith organizations to include disability as a social justice issue. And quite frankly, also equity issue. Join national coalitions and organizations concerned with disability rights and health equity agendas. And lastly, seek relationships with universities. We're hearing about Duke, and there are quite a few other universities, I'm sure, including Georgetown, that it's really looking at conducting studies that really have partnerships between faith-based organizations and communities to decrease health disparities. We know that some of this work is being done. It's not in published literature. It's not necessarily in social media, and it needs to be recognized and more prevalent. I'm going to end on a couple of thoughts. The American Public Health Association has a platform and an agenda that looks at health equity, and that's what you see in a column to the left. I've done some work to really look at if we apply the principles of cultural and linguistic competence to that platform, what would it look like? What difference would it make in the lives of people? APHA says we value all people equally. That's a pretty strong statement. So what does that mean on the ground level? Being able to share power, resources, and ownership of data, and credit individuals and groups' contributions. It means that there's a reciprocal transfer of knowledge and skills, that communities have much knowledge in this area, and we have to be able to respect it. Another principle is we optimize the conditions in which people are born, grow, live, work, learn, and age. And I would say, and share their spirituality, although that's not part of their platform. And so again, in many cultural communities, we need to promote a conceptualization of health that integrates physical health, emotional health, social health, spiritual, and economic well-being, because we need all of those to live well on this earth. So I'm not going to go through all of these. However, I am going to end on one in particular. American Public Health Association took a huge step and said, we name racism as a force of determining how the social determinants of health are distributed. Race is always a very difficult conversation in our country. I believe that, again, and many people, that race is a social construct. It was created back in the day to really show differences among people. I also believe that there's only one race, which is the human race, and that we nonetheless have created a society in which race is paramount. And so I think it's really very important that we pay attention to the impact of racism across the board on many groups of people, including their health and well-being. So I'm going to end on a couple of reflections from Martin Luther King in particular. One image depicts his arrest in 1958 in Montgomery, Alabama. And I found this quote that says, "Faith is taking the first step even when you don't see the whole staircase." And clearly, as I look at this arrest, that was him taking the first step. And Martin Luther King also said in 1966 at a conference, "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." Very, very, very powerful words. And we'll go to Margaret Mead, who indicated, "Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has." And that's what this community is right now. A small group of thoughtful, committed citizens that can indeed change the world and make a difference for people with disabilities who experience health disparities across racial groups, ethnic groups, and other groups in this country. So I'm going to stop here and ask you to contemplate what we've shared, but the action steps that you can engage in at an individual level, at a congregational level, at a national level, or a state and local level, and then we'll come together and close. you like to share some of your discussions and or some of the work that you're currently engaged in to address health disparities? And I see a couple of hands.
Yeah, I just had a question. If there's much of a disparity between people with disabilities who live in their family versus those who live in agencies.
Could you just repeat that? I couldn't hear you.
A little closer. Okay, those too loud. Sorry. I was thinking that there would be a less of a disparity between those who live with their families who are disabled versus those who are disabled who live with an agency. We have nurses in our agency, and so I think they're there often and daily. I would think that they are advocating more for so that they get the health care that they need. Sometimes in a family, it could easily be overlooked by the doctors and the healthcare system.
All right, so we look at our healthcare system as being quite complex, and even though residential services may have nurses, that may not be all of the meet all of the healthcare needs that we articulated. We talked about diagnostic tests, we talked about early prevention and detection, we talked about a variety of things. So I think that that there are not many studies that have really examined that in great detail. But I do want to encourage you to think about this systemically. So that there is incapacity within a system as opposed to a residential setting. That incapacity and particular knowledge among healthcare professionals to address the population still would have significant weight across the board. I also think that when we look at accessibility, many people, women who couldn't get mammograms, it's because the diagnostic equipment wasn't accessible. So there are a lot of complex, I think, issues that will indeed impact the degree to which we see disparities in residential settings versus home settings.
University.
We are providing equipment for medical professionals.
We are developing a curriculum for medical professionals
To help educate them on disparities.
to help educate them on these disparities.
One of the things that I've learned is the lack of empathy between medical professionals because
One of the things that I've learned is the lack of empathy between medical professionals
the people with disabilities
and people with disabilities.
and the lack of conversations, meaningful conversations.
And the lack of meaningful conversations.
So I think it's important that individuals with disabilities be present.
I think it's important that people with disabilities be present in conversations.
And those with different cultural backgrounds
With those with different cultural backgrounds,
be at the table during the conversations.
be at the table during those conversations.
Thank you for your comments. A couple of things I'd like to reflect on that. If we look at how research has evolved, there have been health disparities research that is focused largely on race and ethnicity. Then there's health disparities research that is focused largely on disability. as if people don't have that intersectionality. So that's one problem that we have. I also think that when we look at training healthcare and medical professionals, that there's a different mental model and worldview when we think about people with disabilities. So that we believe that disabilities is a natural occurrence in life, period. Many within the medical and healthcare communities have been taught to only view disability from a disease or impairment perspective. And somehow the human is lost in that. So I agree with you that we have to have not just curricula, because you can have really great curricula. It's about who does the training, including people with disabilities. It's about the kinds of experiences that healthcare professionals get, and that they, again, have an opportunity to view disability as not as something, quote, special, but again, a natural occurring part of who we are as human beings. That requires attitudinal change. That will require systems change. I'm very glad that Virginia Commonwealth University is beginning to take that journey.
Questions or stories about David Gates?
I just want to say I really appreciate your presentation today and your words, and I appreciate you bringing up the healthcare bill lesson. I was one of millions of people with disabilities that advocated in many ways to save healthcare, and I was thinking about the members of ADAPT, because so many people with disabilities that put their bodies and lives on the line to stop this horrible legislation, and that would limit the quality of life for me and so many with disabilities. And as I was advocating last summer, as I was doing my work, I noticed how the faith community seemed largely silent as a whole in terms of advocating on this issue, in terms of standing as an ally for people with disabilities. And I really thank you for challenging faith communities to step up and put our theology into action and to stand in solidarity with people with disabilities. So I was wondering if you want to touch on a little more on those thoughts, particularly in relation to healthcare and what's going on currently politically affecting people with disabilities.
So thank you for those comments, and thank you for your advocacy and actions. We still have political problems with healthcare. And most recently, there are political problems as it relates to changing some of the requirements that in the Affordable Care Act that currently exist, including pre-existing conditions. Let's get your words out. Pre-existing conditions, so that currently there's I was going to say strategies, legal strategies, not to defend that across the board. So I look at life being a pre-existing condition, so that that we still have a lot of work to do. And I think faith communities can be very powerful voices to help in that arena.
We pride ourselves somewhat on pastoral care, and people as inclusive congregations, and are also people who are chaplains in hospitals. And one of the things I think is simply to be aware of what's going on with people that you know with disabilities when they're in hospitals or medical settings, and kind of small ways of standing with people and their families vis-a-vis things can make a huge difference. I think about a family in New Jersey who moved into the state looking for a doctor, and they took them 50 calls before they would find a doctor to serve their son who was in his 50s. And I also think of a story we heard in Atlanta of when we were there about congregation, an older African-American woman who had a daughter who was multiply disabled. She had never had any services from the service system, and the mom died, and the family had been involved with the church, and the church went to the social services, to Social Security to say the mother's benefits should pass to the daughter, and according to Social Security, they said back to them, she doesn't exist. We don't know that she's a person. And in fact, it took then the church showed up with 25 people and the daughter at Social Security office saying, this is who this is. We know who she is. You've got to recognize her. And in fact, they pushed that through so that those benefits could continue, which is a really powerful way of saying, we're standing with people. We know what you're doing, watching what you're doing. This person deserves what anybody else gets. Yeah.
Thanks very much. And both the health disparity as well as discussions about theology can put lots of medical perspectives to disability. And it's really, really interesting. Thank you very much for bringing to the attention the United Nations conventions and language of rights-based approach when it comes to developing how different congregations interacting with disability. Especially, this is to be great if you could elaborate more on that, because especially in the issues of health disparity, we have lots of confusion between what models of disability that people can follow when it comes to stuff. Is it medical perspectives? Is it a mixture between both medical and social perspectives of disability? Bringing these discussions to the mosques, churches, and other congregations can entail lots of discussions. Having originally from Egypt, and we have lots of problems when it comes to connections to mosques and how speeches could be delivering more medical and charitable perspectives, care approaches to disability instead of rights-based one. So more elaboration would be useful, and it's really fascinating talk. Thank you very much for that.
Thank you. There's one here, and then I guess we should be closing. Actually, two.
I'm concerned about let me see the mic. How do we address between sort of talking about sorry, let me find it. For those of us that do advocacy work at the grassroots level, and we're deeply involved in last year's conversation, I'm concerned about the over-medicalization of disability and how to maintain the conversation around healthcare while acknowledging that for many of us, our underlying health is really pretty good, and to often enter this conversation from a medical perspective limits what we can do and what we can say about our underlying health. But yet, knowing that we need to be talking to medical professionals so that the overall trajectory of the conversation can change. And threading that needle is very challenging. So, I'm both grateful for your talk and very
statement. I think that when we look at, I'm going to go back to my graphic that looked at policy. So that if we have policy that only looks at disability through a medical lens, that's what services are going to be. So as we talked earlier, looking at disability as a natural occurrence in life and understanding that just because one has a disability does not make one unhealthy is very important. And so part of this is about education, and part of this is about policy change, because we have a funding structure that has put disability in a box to say in order to receive services, you get these services through Medicare and Medicaid and or Social Security, unless you have significant resources. I'm not sure services and supports should live in those boxes, but that is about significant systems change and advocacy that would need to happen to look at the funding structure for how we support people with disabilities.
One more.
Okay.
Warren?
Thank you very much for your talk. I work with congregations around mental health questions, around advocacy, and I'm so glad that you showed the picture and name of Diamante Driver, because what I found in that work is that congregations often aren't motivated by actions and statistics, but they are motivated by names and faces, especially of those with whom they're connected.
Yes.
And so that's just really important in that kind of way of building those kinds of relationships. And then also, my impression, at least in terms of how congregations sustain this sort of work, at least with respect to mental health, is not from kind of top-down initiatives from denominations or even from clergy, but from committed groups of people within a congregation who really care and want to continue to patiently work across time for change. And so one way that congregations can help to sustain that work is by not putting those people out on their own, but by supporting people who really care about these questions with resources and with people and with advocates and with money. And so in terms of congregations moving toward the kind of advocacy that you're mentioning, focusing on what does it mean to help sustain those people who most deeply care and to expand those circles more broadly.
So thank you again for those comments, and I would add that congregations can't stop there, that they really have to look at things at a higher level, including state level and national level. Everyone may not be involved in that, but we know that the complexity of services and supports for people with disabilities has to be addressed at that level, and congregations need to have some discussions in terms of not only what they can do individually and locally to help people, but also how can they be a great influencer toward transforming our systems. And I believe that faith communities have that power, have that voice, and need to step up. Thank you.
Help me thank